We will be presenting a two-portal technique with Bennett lesion resection and posterior labral repair in a collegiate baseball player. Bennett lesions can irritate the capsule and be a source of pain during the late cocking and follow-through phases of throwing. They can also compress the posterior rotator cuff and the labrum, leading to rotator cuff inflammation and tearing, as well as posterior labrum pathology. The benefits of our technique include its easy reducibility, quickness, and strong and high-quality repair with only two portals, as well as knotless anchors. Viewing from the anterior portal and working through a posterior lateral portal that can be utilized for both visualization as well as a working portal. We typically place this portal midway between the standard posterior portal and previously described 7 o'clock portal, which is 2 centimeters interlateral to the posterior lateral corner of the acromion. In this instance, we utilized a probe to identify the hypertrophic capsulolabral tissue as well as the site of posterior labral tear, which we were able to work through the site of labral tear with a sucker shaver device for further exposure of the Bennett lesion. Additionally, an electrocautery device can be used through the site of tearing to further reveal the entirety of the Bennett lesion. Once the lesion is fully identified, a 4 millimeter round burr is utilized to resect the Bennett lesion. In cases where the labrum is frayed but not detached from the glenoid, the Bennett lesion can be accessed through a posterior inferior capsulotomy. Although we were able to access the Bennett lesion through the site of labral tearing, we prefer to perform a posterior capsulotomy to address the posterior capsular contracture. Our patient in this case had a 30-degree lack of internal rotation compared to the contralateral side, consistent with glenohumeral internal rotation deficit. We utilize a 90-degree hooked arthroscopic electrocautery device to perform our posterior inferior capsulotomy from 3 o'clock to 6 o'clock in the left shoulder and 9 o'clock to 6 o'clock in the right shoulder. Care is used to stay just off the labrum as to not damage the posterior rotator cuff tendon. In instances when a posterior labral repair is required, we utilize a winged Gemini cannula. Posteriorly, in our experience, the wing design prevents the cannula from backing out of the joint during this procedure, which can frequently occur with traditional screw-in cannulas. A drill guide for a 2.9 by 12.5 millimeter peak push lock anchor from Arthrex is then placed in appropriate position on the face of the glenoid. We find it most efficient to place all the drill holes prior to anchor placement to limit the number of instrument passes. The drill holes are lightly marked with a small tipped radiofrequency ablation device for later identification. A 90-degree suture passer is then brought in through the posterior cannula and passed through the capsule and under the labrum. A shuttling wire is then advanced into the joint and retrieved through the same posterior portal. By grasping right where the wire comes out underneath the labrum, we find that this avoids any tangling. A 1.3 millimeter suture tape is then folded over and shuttled with the wire. The suture is loaded into the push lock anchor and is tensioned appropriately. The anchor is then advanced into the pre-gelled hole. The suture is then cut as flush as possible to avoid suture irritation of the cartilage. Sequential placement of anchors is then performed in the same manner.